My name is Melissa Federa, and today I will be discussing with you my top 5 papers, which include CDS alerts and fatigue and what is the evidence. Austin's very advanced in the EMR space. I've been part of the clinical informatics unit since 2010, whereby we were one of the first hospitals that did electronic prescribing, electronic prescriptions, also electronic pathology, radiology and discharge summaries. A few years later, we replaced the National Inpatient Medication Chart and did administration on Cerner. Since then, there have been a number of modules that have been added to our collection, including the ED module, FirstNet, Physician Handover, Task Manager, Community Mental Health. We do and continue to do clinical documentation. Our recent go live last month was for Cerner Oncology, and also I've been working with Telstra Health on a community pharmacy medication repository, ERX, for hospital pharmacists to see the patient's active prescriptions. So why this topic? I wanted to review the literature and look at the current evidence and different research strategies used to understand the evidence for alert fatigue. I wanted to understand more about this because we've been live for so long. Nobody from my group has looked at alerts and alert override rates in the system, so I wanted to apply some of this knowledge at our hospital. The search strategy I applied was using a number of different databases, restricting academic articles to years 2015 to 2017. There were a number of different search terms used. It brought back 76 articles, whereby I shortlisted 22, then obtained 10 full text, and out of that 10, I selected 5 articles. This first paper was selected because it looks at their drug-to-drug interaction alert recommendations. These recommendations were made by a group of 24 experts in different disciplines, including clinical informatics, computer interface design experts, academia, health IT, vendors, clinical users, hospitals, and also government. So this user group looked at these recommendations over a 13-month period and pulled out the most important things of how and what should display in a CDS alert. So the what to display, the theory they came up with was called salience hierarchy. It looked at 7 different topics to be considered for a drug-to-drug interaction alert. The drugs involved, the clinical consequence and frequency, its seriousness, its recommended action, so guidance on strategy of how to mitigate that potential harm, put it in context, so if the interaction is based on somebody's creatinine levels, then providing those creatinine levels if a dose needs to be reduced because it's renally cleared is important. The mechanism of action, of interaction, this was recommended by the usability work group. Unfortunately, I didn't agree with the mechanism of interaction being included on the display alert because I felt like that was just adding too much information to an already cumbersome and wordy alert with their recommendations. The evidence was not part of the alert, but data on file, if required, it could be accessed. So how to display? So the consistency, terminology, colour, layout and language, and it needs to be readable without a disruption of flow. Where to present? So I guess where is an essential information in a single dialog box with all the salience hierarchy points as discussed previously. When to display? At the right time in the decision process. So this comes back to the information about without disruption of flow. So this discussed when an ordering physician orders a medication, the alert should fire at the time of ordering, and not after an ordering conversation has been completed and when you're at the process of signing all the medication orders you've ordered for the patient. So it's at the time of the actual drug-to-drug interaction firing. So how to resolve? So the actions, once an alert is fired, what happens next? There is a set of actions for you to address. It could be to continue ordering or cancel the order. If you do decide to cancel the order, it will cancel it from scratch, but if you decide to continue the order, then there should be a set of override reasons that are codified that can be actionable and can be analysed further down the line. This paper by Sampaio et al. Was very interesting. The Philadelphia Children's Hospital actually devised a clinical dashboard. So it was an analytic dashboard that identified clinical alerts. So their aim was to develop and evaluate an electronic dashboard of their hospital-wide EMR to identify high-rate alerts that were causing alert fatigue and look at reducing these alert numbers and improving the quality of alerts that were coming through the system. So the theory behind it is alerts have high sensitivity but low specificity are mostly irrelevant. And those that were used predominantly by physicians, nurse practitioners or pharmacists had high rates of medication alerts exhibiting fatigue and then potentially missing or overlooking the clinically relevant alerts that can cause an adverse drug event or potential harm. So there are different types of alerts in the system, particularly the ones that they looked at were allergy, maximum dose alerts, duplicate checking, drug-to-drug interaction. Their alert comes up on one screen and can measure a number of things separately or all in one action. So the action is either override, cancel, remove or view. The alert will fire continuously regardless of the previous action taken. So this hospital invested in a visual analytic web dashboard that had user interface testing and was supported by a number of hospital committee governance groups, including EHR leadership groups, CDS committees, med safety and therapeutic standard groups. It also included risk management, legal and clinical informatic councils. The dashboard looked at all alerts firing between 2011 to 2014, which was 6 months post an EMR implementation. Prioritised from all the different firing alerts, the most important one was drug-to-drug interaction in the inpatient setting, which consisted of the highest volume of alerts. This screenshot you can see here of it's called a medication alert fatigue analytic app. You can see here it has a lot of different filters and a lot of different measures. So I guess you can filter down to encounter type, which is on the left hand side, alert type, when the alert fired, the alert action, override rates, frequencies, and then you can absolutely drill down to the individual patient and user. So the data that was collected during the time frame was used to analyse the most overridden, irrelevant drug-to-drug interaction alerts that were approved by the CDS committee, and clinical pharmacist committee did a comprehensive literature review to actually determine whether these drug-to-drug interactions were clinically relevant. If they were deemed to be clinically irrelevant, they were deactivated from firing. The hospital's therapeutic standard committee were the final arbiter of the removal of the clinically irrelevant alerts. So they did remove a number of alerts in 3 stages. The first stage was at week 20. They removed the interaction of benzodiazepine and ethanol, which were the highest override-ridden drug-to-drug interaction. The second week, the second round on week 45, they removed 42 alerts, and week 58, they removed 19 drug-to-drug interactions. So you can see on the second graph there, the three different intervention time points and how much the drug-to-drug interaction firing was reduced. So it reduced from 58.74 to 25.11 per 100 orders. And that was for the pharmacy group. And for the provider group, which was the physicians and the nursing practitioners, it was still statistically significant, but didn't fire overly high to begin with. So it went from 19.73 to 15.11. So it showed a decrease in the override rates in the, after deactivating the clinically irrelevant alert rules. So their major findings were that the pharmacist alert rates were significantly reduced with the removal of the alert interventions at time points 1, 2 and 3. No recorded medication safety issues with the removal of the 63 alerts, so it was safe and appropriate to remove these alerts. The reduction of alert burden was reduced, and also the clinical dashboard continuously dynamically monitors the electronic health record medication alerts and remains the integral part of the hospital's quality improvement initiative. This paper by Topaz et al. Was selected to analyse drug allergy interactions with opioids. The method they used was they analysed 10 years of data from 2004 to 2013, including 2 large academic hospitals in Boston, using a longitudinal allergy database named PAIR, Partners Enterprise-Wide Allergy Repository. Their aims were to describe the prevalence rate of opioid drug allergy interaction alert overrides, examine the nature of opioid-related allergic reactions, and examine the factors associated with providers' tendency to override opioid alerts. So what did the results show? The results of prevalence rate of opioids definitely shows an increase in override rate, as shown in Figure 1. So the alerts for opioids are about 5% higher than all meds, sitting at 88.8% alerts were overwritten for opioids compared to 83.9% for all meds. The absolute values, if you look at override rates, started at about 10,500 in 2004 to 55,000 override alerts in 2013 for opioids alone. There's definitely an increase in override rate. So the second result looks at the frequency of life-threatening or immune-mediated reactions. Only 10.4% of all alerts were life-threatening and were overridden 87.8% of the time, whereas non-life-threatening overrides were only 89%. So I guess looking at this result here, even though 10.4% of these alerts were life-threatening, so that the allergy that the patient had against that drug, whether that be bronchospasm, angioedema or severe hypertension, they were still given and they were overridden at a very high rate. Result 3 looked at the factors for users to override alerts. So the type of alert overrides overall, so 10% were exact match, so only 10% of the time the exact match were overridden. Exact match being the exact name of the drug that was ordered was overridden 10% of the time, and 90% for cross-reactivity. So cross-reactivity describes best match, so that means if a patient was allergic to an opioid, in particular morphine, it would fire for any other subsequent opioid that was ordered in that ordering conversation. Compared to life-threatening, which 70% of exact match were overridden. Table 3 shows the drug allergy interaction alert override table. that 29% of all patients has tolerated a drug previously. Almost half in that category were unknown, and unknown means that the override reason was not documented, so they had no idea why they were overridden, and there were about less than 20% were in an other category, which was just free text answers. So overall, a very interesting paper. This next paper looks at two theories of alert fatigue: cognitive overload and desensitization. So the alerts that were looked at in this study were the best practice advisories, the BPAs, which are clinical reminders and recommendations, and also the CDS alerts, including drug-to-drug interactions and drug allergy interactions. So cognitive overload was defined as alert fatigue is caused by receipt of a large quantity of information along with insufficient time or cognitive resources to distinguish relevant from irrelevant information. So the method they used was they looked at the markers of complexity of work, including alerts received per encounter and comorbidity index of the clinician's patient. They measured repeated alerts, as they were defined as alerts presented to the same clinician for the same patient in the same year. So the results, they found that there was an acceptance rate of alerts, and this decreased with the more alerts and the more repetition. But the complexity of work was inconclusive. So they concluded that the primary care clinician became less likely to accept alerts as they received more of them, particularly as they received more repeated and therefore probably uninformative alerts. The complexity of patients was not a factor, as they could not prove that the more complex patients had less acceptance of alert decrease. Desensitization. So desensitization was defined as repeated exposure to alerts leading to a decline in responsiveness. So this study, they added 6 new BPA alerts and reviewed override rates over 6 months. The results showed a pattern in declining results, but it was not powered. And maybe a reason for this is 6 months may not be an adequate time for desensitization. So overall, a very good study to look at cognitive overload, and maybe something to take away from that is giving clinicians repeated alerts is not an effective way of communicating a change. This next paper was selected because, like previous papers I've discussed, which were single studies, this is a systematic review of CDS. So systematic reviews have a higher power because they group multiple common papers together. So what did the literature say about CDS? So Joanna Westbrook and her team looked at categories of CDS. She looked in total, their team looked at a total of 11 categories, but today I'm only focusing on the 3 common ones, which were drug interaction alerts, drug allergy interactions, and dose range checking. So for the drug interaction alerts, there were 6 papers in total. 2 papers had a positive outcome, 4 papers showed no significant change, but there was definitely the 2 papers that were positive did customization of CDS alerts, and this showed a trend for better outcomes than just utilising vendor-designed CDS. Drug allergy interactions, the 2 papers were quite neutral, as one was a significant increase in override rates and the second was a significant decrease in drug allergy errors. The third, dose range checking, I was interested in this one because recently we have switched on a few medications with a dose range, and dose range checking is a range that is put on to a particular medication for a minimum effective dose and a maximum dose, and any dosing outside that range will fire an alert. So these 3 papers all showed a significant reduction with the introduction of DRC, so a significant reduction in medication errors, in particular with insulin. So it was very effective to put in dose range checking into an EMR system. So overall, this systematic review showed no clear indication that a particular alert category is better than others. However, overall customization plus vendor CDS has better results. So what were the major findings from my top 5 papers? A dashboard is definitely an effective way to identify alerts with a high override rates. Taking these groups of alerts, analysing them, and potentially switching off the unnecessary alerts will decrease alert firing and potentially may help reduce alert fatigue. Multidisciplinary governance group influence customization of alerts and are a very important part of a hospital when configuring alerts to reduce alert fatigue. Another way is to use simple format structure. Clinicians are less likely to accept alerts if they receive more of them or more repeated alerts, which is also known as alert desensitization. Drug allergy alert overrides are higher with best match than exact match, so maybe consider customizing class effect reactions first. Alert fatigue does exist, and a hospital implementing CPOE will have better outcomes when vendor-specific CDS are implemented, but also are customised for the hospital requirements. Finally, alerts are dynamic and should be periodically analysed and customised to minimise unnecessary alert firing and reduce override rates. Thank you. This is finally the other additional papers that didn't get shortlisted but were an excellent read all the same. Thank you.